to offer me the chance to discuss about a topic that nobody knows really well. Who is using immunoglobulin for treating septic patients in the room? 6, 7, 8, 9? Regularly or exceptionally? Exceptionally more realistically. Right. So we don't know very well what means immunoglobulin for treating the septic patients, what kind of immunoglobulin we should use for what kind of patients, and it's based on the pathophysiology, which is supposed to be well known, but it's rather complex. And what are the consequences for the benefits, clinically speaking, or the immune staff? So I would like to perhaps try to clarify a bit modestly. So just a case we did a couple of years, a young guy, 39 years old, having a streptococci toxic shock, but this came later on after several days story of cephalalgia using non-inflammatory, non-steroidal anti-inflammatory molecules. Then this molecule is creating a lot of things for immunodepression, which favors the toxic shock syndrome. And this guy has an ankle and an index article inflammation with a very, very noisy symptoms of fever for 9 days. And he came to see the surgeon, and the surgeon is always ready to get a solution, as you know, and did the lavage of the article, which was a reasonable approach. And this lavage was, of course, associated with a culture of the liquid coming from the articles, and they found a group A streptococcus. It was treated with the antibiotics, good dosage, good molecules, and the patient was very compliant for this. And the evolution was not so great. He kept going with the fever. He got a new localization of arthritis, which was moving to the knees and the shoulders. Again, he went to the surgeon, and the orthopedic surgeon did a lavage again. And finally, it was not so well, and the surgeon called us and said, would you like to take care of this guy? Because he has a response, a non-responder, you know, the so famous non-responder, which means non-understood patients, more than the non-understanding patients. And then we took the patient in the ICU, and we were in trouble, and we decided to take in account the fact that the Streptococcus A was there, and we imagined a toxic shock syndrome and a super antigen disease, and then we decided to treat rapidly, very rapidly, right away, the patients with immunoglobulin, polyclonal immunoglobulin. And we gave 3 days of 1 gram per kilo of this immunoglobulin, then 0.5 per kilo over 2 days for finally 5 days. And then we observed what happens clinically for the patients. He rapidly improved, but at the same time, he got a renal failure because the immunoglobulin you give are macromolecules, which are not so good for the kidney. And it's not the place to discuss about this, but at place initially, it deteriorated the renal function. So we did some kind of immune monitoring in these patients to know what's going on in this patient when you use the immunoglobulin. And you see in the light blue the polymorphonuclear cells evolution in the blood, and you have the dark blue, the lymphocytes, and you see the HLA-DR expression on the monocyte, the circulating monocytes, which have been measured with this flow cytometry. Initially, before coming to the ICU, he was expressing well in the monocytes the HLA-DR, which means that he was not so immunosuppressed. He was functioning normally. Then, after the immunoglobulin, we see a quick decline after the immunoglobulin, a quick decline and a deep decline in HLA-DR expression on the monocytes. And then we stopped the immunoglobulin after 5 days, and it started to re-express the HLA-DR on the circulating monocytes. And you see the polymorphonuclear cells went down, and the lymphocytes number went up. So the message is that before he got a huge response of the immune function, which is different than the classic septic where you have a downregulation of the system. Then you give the immunoglobulin and you see it downregulate well, which is probably an adapted response. It downregulated well the immune inflammation. At the same time, so we measured, of course, the level of immunoglobulins, the IgG level before, during, and after the IVG infusion, and you see we move from 5.5, which is a bit low level of IgG, to 16.5 level, which means that we replace well this immunoglobulin level. And then we were happy with this, and the patient recovered rapidly and has no more problem after that. So going back to the literature, so what we know is the toxic shock syndrome is something that we learned many years ago, and it's fortunately not so frequent. And when we have this kind of patients, we know that it's a very fast process. It can be very dangerous and can lose the patient in a couple of hours. So this has to be recognized and rapidly treated, which means making a decision which is not easy to do. It's a toxin which is usually playing the game of overactivating the system with no chance of a downregulation or adapting the immune response for the quality of life of the patients. And then you move rapidly to the multiple organ failure, and most of them are at risk of death. The most dominant expression of this is produced by the Staphylococcus and the Streptococcus with very specific strains, releasing very dangerous toxins. And the toxic shock syndrome is acting as a superantigen, which means superantigen means that you get a big antigen, but more essentially it means that you are bypassing the system of controlling the expression by the antigen-presenting cells, presenting the antigens to the lymphocytes, and then having a cooperation and adapting the response quite well to the necessity. With the superantigen, you arrive, boom, and you overexpress and you overcommand the lymphocytes to respond, and this response is probably quite non-adapted to the situation. So this is here the antigen you see in yellow, and you have a cooperation between the antigen-presenting cells and then the lymphocytes. They cooperate through the MHC class II expression, which is the HLA-DR. You can check numerically with the flow cytometry. And then when you get a superantigen, so you bypass this phenomenon and you get a huge release of cytokines, nothing is able to be adapted, and you get a storm of this, and that's the reason why you get some toxicity at the organs, and you die with a multiple organ failure because of this non-regulated immune response. If you go to in detail, you see normally the MHC class II, the HLA-DR receptors on the monocytes, is presenting the antigen. Unfortunately, you get a lot of associated keys to be sure that the things are really fitting well together. The antigen is presented, but you have cofactors which are going to be together to be sure that the response is adapted. With the superantigen, you have immediately a very strong and stable of this superantigen, which is activating the lymphocytes response, and there is no chance for regulation of this phenomenon. And you get a huge release, a storm of many cytokines, especially the ones which are released very early in the process. So finally, the factors which are really important to consider when you give this immunoglobulin IV injected is, first of all, you have a very fast turnover rate of this immunoglobulin in patient's blood, and the IVG could be beneficial only at the early phase. Early phase means really a couple of hours, maybe 5-6 hours in delay. That might be the maximum. This is the window where you can be very efficient to block the system of the superantigen disease. After that, the game is over. You do the same, but it doesn't work anymore, and you can say, oh, the trial is negative. We tested a trial 12 or 24 hours or 2 days after the beginning of the study. It doesn't work, so immunoglobulin is not good. No, it's not the immunoglobulin which is not good. This is the design of the trial. You arrive too late for the process. And the efficacy for this immunoglobulin, we don't know very well what is in this presentation of immunoglobulin. So you have several manufacturers, and you don't know exactly what is in. You know there are some IgG, IgM. You know the proportion, but you don't know for what kind of receptors they are supposed to be. So finally, you get a bottle, and you inject the bottle, and you see what happens. But at least do that very early. That's very important for the future for the patients. What else in the literature? Nothing really very exciting. So if you pull the data, you can see that you have case reports, you have 2 observational cohort studies, you have 1 case control study, and you have a 1 multi-center placebo-controlled trial, which is a very small one. So finally, the clinical data are not really definitive. So we need more to be sure that it's efficient, first of all, and safe, and it can save lives. So, but this is delicate clinical trial design. So Mani Shankar resumed this nicely recently to show that finally when you screen the literature very carefully and rigorously, you have only 8 observational studies and 10 studies you can include with more or less poor quality, and to have a decision based on that is quite impossible for the moment. So the dosage and the timing, I repeat, is a very important one. So you should give this during the window. You have to monitor the level of immunoglobulin every 12 hours. It's safe for the patients to know where you are, and you stop when you reach a level over the normal value of immunoglobulins. By which way it works, we don't know well. Is it a replacement efficacy, or is something which is really blocking the toxin effects? So we don't know. Maybe both of these mechanisms can be associated with the success. And these factors are very difficult to assess at the initiation of the treatment. So you see what happens after, but you don't know exactly by which way it was efficient. So to conclude about this, the passive immunotherapy with immunoglobulin seems to be very logic, based on the quite well-known pathophysiology, the antigen, superantigen disease. But we have something which is a blinded polyclonal immunoglobulin you give, and you make the bet that this will block this toxin or toxicity of the toxin. And this is important to be given even in excess. If you do a mistake, apparently there is no bad consequences to overtreat the patients with immunoglobulin. So you have to compensate the level of immunoglobulins at least to the normal level, so you can infuse until you reach a normal concentration of immunoglobulin G. And the limitation for this is we don't have a really clear data coming from the literature. So thank you for your attention.